Thank you very much, Roger, for the kind invitation and for organizing all this. It's great. As Roger mentioned earlier, we met at a meeting for the first time in Morocco, and from the discussion, this meeting eventually happened. I feel a huge pressure now because almost all what I want to say has been said. And you still expect me to add more new stuff. We'll see whether there will be anything new or not. I think, to me, I was saying to Roger, I was thinking, what's the point of having me at the end? But listening to all of this and listening to your questions, I hope that eventually, at the end of the day, you will go home with some positive messages. I would also very much like to thank Stephen here for this, for his support for developing these guidelines. Diabetes and Ramadan is something very new. It's like a baby just been born a few years ago, and it's evolving. And every year, like a baby, you see a 1-year-old child is different from a 3-year-old child. You can see the huge difference. And about 18 months ago, when we were discussing the possibility of doing these guidelines, and Stephen stepped in and he said, I'll put you in the right direction and will help you and support you. And hence, this is a copy and paste from the actual guidelines of acknowledging his support for this. The guidelines have been developed from not just these 12 names, these were the main authors. There are another 19 names, you can find them on the guidelines from all across the globe. They didn't start, the IDF is the consequence of the 2005 and indeed some other work done in 1995 before we stepped in, but there were many guidelines. And I throw in the Sudan guidelines, not because Sudan is the most scientifically robust country, but for the importance of every single country need to look into their local needs, local background of patients, and modify what is international for what is required for them. I think this has been covered before. I want to just add to you one point. Marwan have mentioned this before from the CREED data that we did in 2010. People with diabetes and Muslim background, they want to fast. What this slide is saying to me, that at the beginning of Ramadan, 94% wanted to fast. They are passionate to fast. And everyone here is mentioning the word challenge. What I think you should go home with is utilize the passion of the patient instead of the challenge. So if I'm a Muslim and I'm really keen on fasting, channel me into how can we get your diabetes better because you're really keen to fast Ramadan. Or if you have something very strong scientifically, then maybe you can be strong enough and not just go with the flow and tell me, Mohamed, because of your medical condition, you must not fast. Now, if I insist, it's a different matter. It's like a heavy smoker who have asthma. You don't tell them, okay, go and smoke. You tell them, it is pretty dangerous you smoke. So if I have hypo-unawareness, then it might be very appropriate for you to say, please do not fast. But if I insist on fasting, it's a different matter. But what's important from this slide as well is, out of this 94% who really were passionate to fast, only 64% of them managed to fast the full month. That's one important point. The other important point is what Alif have mentioned is different cultures. So from the data that I'm showing you here, Algeria and Morocco are two neighboring countries. Door to door, same culture, same geographical region. However, the medical advice in Morocco, in collaboration with the religious advice, simply says, if you're on insulin, do not fast. So the patients are hearing a homogeneous message wherever they go. So 22% only fasted the full month, while in Algeria, it's a different message. So it's just important that we go home with harmony. We have a plan that if the patient would go to Melbourne or Sydney or any other city, they ideally should get the same message, even if the evidence is weak, until the evidence becomes a bit stronger. I think we've gone through this, so I'll skip through it. What happens in Ramadan is a completely different physiological status. in normal days, like the inner circle, you have 3 meals and you sleep at night. Regardless of whether you're working or not working in Ramadan, you will wake up pre-dawn. It's not sunrise, it's dawn. So it is about an hour or an hour and a half before sunrise, where you would need to wake up and have a meal. And if you have diabetes, this is quite important. I know many people would prefer, because of work-wise, I'd rather sleep. I'd need my sleep rather than my early morning breakfast. But if I have diabetes, I need this food to go through me to help with some support during the long fasting hours. That disturbance in sleep have a quite important hormonal and sleep changes that can affect the individual. So it's quite important that we understand what happened. Satiety and hunger during Ramadan vary quite tremendously. If you go look into the here, this is out of Ramadan. And as you can see, hunger happens at the right meal times. So you wake up in the morning, you're a bit hungry, by lunchtime you're hungry again, and then in the evening you're hungry. That's what the normal. But in Ramadan, because of the fasting, you see here the data of males and females. So as the fasting carries on, the hunger increase. That's in males. And that persists throughout the month. So data from the beginning of the month are no different than data from the 24th day. However, as I mentioned before, men are different than women, and Ramadan proved that. Because for women, they start the month with the same levels of hunger as men. But by the 24th day, they get adapting a bit better to the hunger. So their satiety is a bit better. So Ramadan proved again that men are different than women. What about continuous glucose monitoring data in people who are fasting compared to non-fasting? Blue is non-fasting, and as you can see, if you're a healthy individual, throughout your normal days, your blood glucose levels will not vary too much. If you're a diabetic and you're not fasting, it will vary a bit at meal times. But this is very important because red is fasting, and CGM data tell us that closer to evening, so in the late afternoon, closer to evening, is when the blood glucose level dip. And obviously at the time of iftar, at the time of the main meal, here start the feast. And Ramadan is a month of fasting. That is true. But also Ramadan is a month of feasting for 30 days. As I say, it's Christmas for 30 days. So don't forget this. Of course it varies from culture to culture. And it's very important that we understand what is the habit of the individual. And that also impacts on one of the questions. What about exercise? You've mentioned exercise. So if I were to advise a person who's fasting, I come from Alexandria, in Egypt, and we have a huge sporting club. And the jogging track in Ramadan is packed. You cannot run. Maximum you can walk. That is for people who are not diabetics. But if I'm diabetic, is that the time before iftar, the right time for me to exercise, or I better exercise in the evening? So it's quite important that we don't say to people, Ramadan is a month to be lazy and sleep. Of course, it's a religious month, and many people would like to read Quran or go to the Taraweeh prayers. Not everyone would, but some would. But on top of this, if you want to play your tennis or your swimming or whatever, then choosing the time for this would be quite important, and that's one of your advices. We've gone through these risks, and we've gone through the hours of fasting. I really would like to pinch the slide of Sarah of the different hours of fasting in different countries. As I have done my homework, and I think for you guys here, it's roughly between 11 to 12 hours. So we've gone through the hypo and the hyper as Marwan have presented. Ketoacidosis. When we wrote the first guidelines in 2005, we thought that a person who had a recent DKA over the last 3 months is probably a vulnerable person, and maybe we should advise them not to fast. But we didn't have evidence. Most of the guidelines are expert opinion. So we wanted to get some of the evidence, and we looked into this from UAE, and then the following year, I didn't have the reference put it yet, from 4 different countries. And we have found that ketoacidosis during the month of Ramadan is higher than the month before Ramadan. What was surprising is ketoacidosis in the month after Ramadan was even higher. And that's possibly related to many people are cutting their insulin doses, they are feasting for a month, and then come the Eid, the feast of the last, after Ramadan is over. So maybe there's the overindulgence and the reduction of the dose of insulin during the month. But when some of the colleagues were saying to me, why on earth should we advise someone who had a DKA 3 months before? We looked into this data, and those who had the DKA during Ramadan had previous DKAs throughout the year. So a person with frequent DKA is someone you should say to him or her is, please rethink. So at the end of the day, it is all about safety. A Muslim person is following his religion is to protect his body. There's no religion that advocates harm to the body. And the core of essence of Islam is to protect the body. So if we're to advise a person based on this, it all depends on how you come across with your message. So it's not a blanket no or a blanket yes. I have to look into every single individual based on type of diabetes, type of medication, my own individual risk. So a taxi driver is different than a person working in an air-conditioned office. Having a hypoglycemia while in an office is different than hypoglycemia while driving. So my threshold for the change in treatment varies obviously depending on my job. The facts of, do I have complications? Do I have renal complications where my risk of hypoglycemia will be higher because of the fact of the retention of the drugs? My social circumstances, not just my work circumstances, but am I a person who live on my own and maybe a bit of the older generation? But if I have someone with me, they might say, you look a bit off, you better check. But if I don't have anyone with me, that's yet another burden, and it's something that you need to consider when giving your advice. Lastly, one crucial point, as I'm delighted that Alif have mentioned in both cases, the individual experience at the end of Ramadan. Because if I come to you and you say to me, Mohamed, have a look at your figures. You had lots of hypos this Ramadan and your blood sugar levels have gone up. Maybe you should rethink for next Ramadan. But if it's the opposite, then maybe we need to take stock from the own individual risk of Ramadan. One very important message. I've heard you talking about the religious and the community leaders. Ramadan is a month of religion. It's not a month of medicine. So it is crucial that you have the harmony with your community leaders. And one good tactics we used to do in Newcastle, for example, in UK, where the local diabetes center invited me, and I collaborated with the consultant and said, let's have the meeting on a Friday afternoon. Invite the community leaders and the imams of the mosque. I will go to the mosque and pray with them, and then we all go together. The first part of the meeting was a general public session for the community and the community leaders, because you really want the imam and the community leaders and the guys in the media to say the same message. If I were to go to the best professor, and then the imam or the sheikh the following day in the prayers would say, do something different, whom do you think I would listen to? So it's quite important, and Sarah have alluded to this, and I will show you again this. So it is very important that you collaborate with your local community leaders, including the guys who talk on the radio, who talk online, and who talk on TV programs, because their message will get to so many people, and it's very important that you have harmony with them. And guess what? The highest religious authorities have no problem whatsoever. If you download the guidelines, you will see the Mufti of Egypt, who is a high professor from Al-Azhar, writing their recommendations with us, agreeing with the recommendations with us, and it's in Arabic and it's English. And it's crucial for you to empower you, because some of you are not Muslims. And even if you're a Muslim, some of my Muslim colleagues say, I don't want to get the burden of making a decision such as this, fast or not fast. That's a huge burden. But none of us should have a burden, because we have guidelines that are evolving. And at least if we pass the same message, that will be quite important. This is the study that Sarah has mentioned, and I picked a different message from the study. The fact that these women were unsure not to do, and they were asking family members, as much as asking the imam, as much as asking the healthcare professionals. Now, I don't blame these ladies, I blame us. Because if we were proactive, seeing a young female in the fertile age and with a Muslim faith, now Ramadan is going to come every year and pregnancy might happen at any time. So if we are proactive and say, okay, if you are to get pregnant and you are diabetic, here is my advice. Exactly like when you see a teenager and you say to them about pre-pregnancy counseling, make sure before you get pregnant, have the folic acid and have the good glycemic control. Same message for a Muslim person is, what would be my advice if you are pregnant? Rather than leave them confused and who should we ask? Now, the risk categories are not terribly different from the 2005. We just made them slightly different as a traffic light. Red, amber, and green. You can go through the items bullet point by bullet point. I think you probably will need to download the document. And the beauty is having this with the IDF, it's a free download. You can have the full PDF as a free download. But the point is, the religious authorities were far much kinder than us as medical profession. When we said red, they said fine, must not fast. When we said amber, they also said fine, must not fast. When we said green, so kind of like metformin or diet control or DP4 inhibitor, they still said it is up to the individual to feel whether there is a burden on the individual or not. So it's quite important that we do not play the role of gods. I should not be sitting in a clinic and saying to my patient, well, what's your problem? You're on diet only, or you're on metformin. You should fast. My patient might feel it's difficult, might feel that maybe because of the hyperglycemia or whatever it is a higher level of burden. If Islam and God, who, if you believe in Islam, you have Allah who says to you, you're okay not to fast if you're traveling. If you're flying from Melbourne to Sydney, you're exempt from fasting. So what about if you have a medical condition? So if the person or the creator who said this about religion, it is okay for you not to fast when you're traveling or when you have your menstrual cycle, then it should be, it's up to the individual. I don't wake up as a Muslim in Ramadan when I have a cold or a flu or a bad toothache and I say, I need to go and get a fatwa, whether I would fast or not. You make your own decision. And that's what the scholars are saying to us, and I have learned from this. Because we were spending a lot of time on doing the risk category, but at the end of the day, the ball is in the court of the individual of whether they feel the burden. Those of you who speak Arabic, al-taqa. So it is the ability of fasting without any burden or not. And that's quite important. What sometimes you have is the professor of medicine have more knowledge than the junior doctor. And the high scholar might have a lot more knowledge than the junior imam in a small mosque. And that's why you really need to get the seniors of the community and the imams on board with you with whatever documents that you want to do. So this is the traffic sort of scheme, and I should emphasize that obviously what we have from Egypt as an Azhar or Mufti might not be applicable in Iran or another country. So you need to get as much as possible harmony with the various sects of the community that you have. Education is the key. It's not the medication. Education is the key. And the education starts first by quantifying my risk, my own individual risk. Then the blood glucose monitoring, even if I'm on diet only. I worked in UK for 24 years, and the NHS would say to me, non-insulin patients should not be doing glucose monitoring. Don't give them glucose strips because obviously they are free. But what about me indulging in feasting? And I would like to know how high did my blood glucose level go on that particular night. Shouldn't I know so that I can change and modify my behavior? So it's not just about hypoglycemia, it's about understanding the behavior that happens. What, for example, happens after, I had one of my colleagues who's a consultant in ER, and we did a study and we gave them CGM. And I said to him, how are things going? And he said, I've learned. Everything now has changed for me. I've now realized that when I go to my Taraweeh prayer with a blood glucose of 200, I feel tired. But when I go with blood glucose of 130 or 140, I feel fresh. So what did the CGM do to him is the knowledge of the differences in how he feels in comparison to his blood glucose level. So it's quite important. I'm not saying that we should all give CGMs, but glucose monitoring would be quite important. Knowing when to break the fast is crucial. There's so many patients, and I think it's been mentioned in the previous presentation, a good proportion of patients feel the hypoglycemia and ignore it. And maybe that's why for some they have the rebound hyperglycemia. But they probably would have felt hypoglycemia symptoms before. And usually it is in the late afternoon. Of course, it depends on the type of treatment. So if your patient would to listen to one message from you in your consultation is, if you have hypoglycemia, stop the fast immediately. Of course, the medication choice, timing, dose are quite important. I will try to cover this. Fluid and dietary advice. You are in Australia and it's Ramadan will be in warm weather. It's not going to be as, well, and in general, your temperature is much better than Northern Hemisphere. So the fluid balance is quite important, as well as the timing of the exercise. And when it comes to fluid, I think some people have the habit of, it's just before dawn, I'm not going to be able to drink for the next 15 hours or 12 hours. I better have a full bottle of water to drink. And I say to people, you're not a camel. Only camels can retain fluid. So you would end up waking up and disturbing your sleep for the next few hours if you were intending to sleep, to go and empty your bladder. So balance your fluid intake throughout the day or throughout the hours that you're able to drink. Structured education in Ramadan is essential. I remember many years ago when I was invited to London to the centre in Middlesex Hospital in Wembley and collaborated with the guys there, and both Vicky Bravis and Elaine Huey were quite keen registrars and documented much of what we've done and published it. But the education worked, and as Marwan have shown these slides, I want you to have a look again. This is the level of hypoglycemia before Ramadan. And this is the level of hypoglycemia after education during Ramadan, which is even better than before fasting. So the level of hypoglycemia was lower while they were fasting. Why? Because of education. And education can happen anywhere. If I were showing you some of the photos from some of the centers in primitive areas in other countries, in a small community center, you can even give it education under a tree if you wish. So there is no replacement for good quality education. And the effect of it, education of diabetes in Ramadan will have a lasting effect. And we've shown this in UK of 12 months of sustainability of HbA1c. And because of this, we won Diabetes UK prize, as well as ESD prize, and then for the sustainability of Diabetes UK again. Not because our program is so sophisticated, but because there was not similar programs. So they saw it as something new and innovative. And I think you have a fantastic opportunity here. So one essential part of behavior change in Ramadan is, when should I check for SMBG? And yes, in some cultures, they think you should not. But there is a general rule in religion, at least in Islam, which is that necessity allows you for anything else. So the fact that I have diabetes and I can be of the risk of hypoglycemia when I'm fasting, so there is a necessity to prevent hypoglycemia. So checking the blood glucose levels when I'm fasting to predict hypo and prevent it happening is quite important. Checking at the non-fasting hours to see not just for hypos, but more importantly for the hyperglycemia, the potential feasting throughout the evening and the night is quite important. As everyone have said, the food all of a sudden change. I come from Egypt, and having this type of food, for example, this lovely dish of dried fruits soaked in syrup, usually sugary syrup. And people forget that dried fruit looks quite small in quantity. But the content of it is the equivalent. So every small piece of sultanas is the equivalent of a piece of grape. But when you put them in a small plate, you don't feel that that's big. So actually, if you were to replace that small plate, that small saucer, with fresh fruit, it will be a big bowl of fruit. That is the calorie content of it. It's just been drained of water, not drained of calories. And the dietitian of you here will know that very well. But the patients don't know that, and they see that as a snack. Okay? As Marwan said, having the... I spoke to some friends from Sudan, and they said they have this lovely drink that they have throughout Ramadan. If you walk in the streets of Khartoum, before iftar, you will smell this drink called helwumur, which means sweet and sour. And I said, well, what's special about it? And they said the sugar content. 1,500 calories in a large glass. And that is daily, okay? In the Gulf, it's the vemto. In the Mediterranean area, is, as Marwan said, Amar ad-Din, the syrup from the apricots. And that is to start, let alone the dates. Well, of course, the dates, breaking the fast with dates, is the sunnah, which is the teaching of the Prophet Mohamed. But I can fulfill this with one. I can fulfill it with 3. I don't have to have 7 or 11. So, passing the message to your patient, they will be passionate to have dates because part of the ritual. Yes, but they can fulfill it with 1. And 1 date is fine, is perfect. As Marwan mentioned, fiber, potassium, sugar, it's quite important. But 7 or 11 is certainly quite excessive. And what happens nowadays, it's a cultural thing. It's not anymore a religious activity. It's like Christmas. It's not just going to the church. It's all the food and the turkey and what have you. And the same with Ramadan, but only difference is for 30 days. So if you were to come to the Middle East, in the evening, this is the sort of atmosphere that you will get. The streets are decorated, loads of food everywhere, and it's open buffet from sunset until sunrise. So eat as much as you would like if you wish. So obviously the person with diabetes is part of the community. He or she would feel deprived if they are not indulging. But it's all about the quantity. So if I fancy having that drink, do I take a big glass, or maybe I should use a small cup? Do I have 1 date or 3 dates, or I have 7 or 11? Do I have the lovely sweet desserts that I'm sure that Marwan will invite me for once in here? But do I have a small piece, or I have daily large pieces of this? So the principle of the Ramadan nutrition plan, what we call the RMP, is they're all there, they're all common logic. Divide the portion of your food, make sure that it's not excessive in carbohydrate. Of course, avoid the high sugary desserts. Making sure to have the evening meal as early as possible, and insist that your patient should have suhoor, the late meal, and as late as possible, so that the gap of fasting would be as small as possible. The advice about protein. Protein, especially in the suhoor meal, the early morning meal, is quite important, because protein with fiber would make the food last longer. So having a bowl of cereal for my suhoor is not the best advice. But having maybe cheese and eggs might be far much better advice for the person, and cutting down on my carbohydrate. And this has been done with studies with our colleagues from Harvard, from Boston. So what we're planning this year should be available for before Ramadan is on the website. There will be the Ramadan nutrition plan with menus of 4 different cultures: the Middle Eastern, the Gulf culture, the Indian culture, and the Malaysian type of food for 7 days for suhoor and iftar, as well as the snacks, based on what is your own individual BMI and calorie recommendation. What we're hoping to do as well is, maybe someone will find it restrictive to have a set menu. What we're hoping to do as well is create your own plate, where as you decide, what do you decide to drink? Water, here is the amount of calories. No, I want to have this lovely apricot drink. How many calories in the glass? So as I'm putting in my plate, hopefully on the website, it will tell me the amount of calories, so I can make my own informed choices. So it's quite important to plan before, it's quite important to give advice for Ramadan, but don't forget this crucial part, which is after Ramadan, make the assessment of the individual. So it's great that you have this meeting here and now in February, because as you guys have mentioned, it's quite important by March or April, whenever you see a patient and he comes from that background, ask them the question. And please do ask the question. I know that in many Western societies, political correctness says, I should not ask a person about his religion, or what does he does, do they fast or not. Trust me, from being a Muslim, I would love that my doctor would ask me if the rationale for the question is to try to help me. But if the rationale for the question is to prevent me having a visa to go to the States, that's a different matter. I can't go through the lecture without a joke about Trump. So, one important message. If in any brochure you're doing clear guidelines on when to break the fast, it's quite important. And it's just not for the hypoglycemia. Many people ask me, what is the rationale of the 16 or 300 milligrams? This is only for people who have good control. So if my control every day is 5 and 6 and 7 and 8, and all of a sudden it doubled, what we're saying is this might be the marker for something else happening. And maybe then you need to say, be cautious, break your fast, or check again, look for ketones if you're on insulin and so forth. And of course, if I feel the symptoms of hypo, and many of our patients, they're not going to be walking around with their blood glucose monitors in their pockets. Some of them do, some of them don't. So in many scientific arena, people say, well, what if they feel hypo? Should they ignore it or not? I think you need to put in context, I am fasting now. So if I feel hypo now, it will be easy for me, Marwan, can I just get a quick snack from outside? That's not a big issue. But if for Ramadan, it means I need to repeat that day. So I'm reluctant to do that. I have already fasted a number of hours. Plus, I would rather fast when everyone is fasting. So that's quite important. Another very important message, you will see that we call it DAR. We don't call it fasting on Ramadan. Because the same implication can happen to the person who is not fasting. So whether the person is fasting or not, they might equally not be eating during the day. They might finding it embarrassing to be eating during the day when everybody is fasting. That's one point. Second, everybody will indulge in all the festivities. So whether you've been fasting or not, whether you had your lunch or not, during the evening, people will still be indulging in all the festivities. So it's not just about the fasting person, but about the whole month for Ramadan, whether fasting or not fasting. Metformin, as you've mentioned, well, if you think that there is 1.5 billion Muslims across the globe, the vast majority of them are on metformin, and we are not aware of problems with lactate with metformin. The dose adjustments is practically not evidence-based, it's just consensus of advice. So if I'm 3 times a day, give me 2/3 of the dose at iftar and the third at suhoor, the evening meal and the early morning meal. If I'm the slow release, then it doesn't really matter what time you give me the metformin. What about sulfonylureas? I was talking with Stephen, and I understand that gliclazide as a molecule is the highly used molecule here, and I'm glad that it's not glibenclamide, because the glibenclamide have been shown in many studies to have, during Ramadan, the highest rate of hypoglycemia. Gliclazide, it was difficult for us in studies to differentiate between whether it's the short-acting or the longer-acting. We plan to do a study so that we can differentiate. But in general terms, if you want to use a sulfonylurea, gliclazide as a molecule is better. And in some studies, it was equivalent to sitagliptin when it was studied. So in general, if it's once daily, then you take it at iftar, reduce the dose in those who are well controlled. Now, how much you should reduce the dose, it depends on the patient lifestyle. So I have a relative of mine, she nibbles most of the day. So when she is in Ramadan and she cut down the dose, it's not still enough. She really need to cut down the dose a lot. Why? Because her lifestyle is nibbling throughout the day. And when she's fasting, of course, she's not nibbling at all for 14 or 15 hours. So when there is sulfonylurea in the morning, she can get the hypoglycemic episodes. So how much you cut, whether 50% or less, it depends on the individual. If it's twice daily, the evening dose is the same, the morning dose should be cut, and obviously avoid glibenclamide if possible. SGL2 inhibitors, at the time of the guidelines, there was only one study from Malaysia on dapagliflozin. And as I mentioned before, the beauty of it being in Malaysia, hot and humid country. So the natural concerns about fluid dehydration and so forth would be well tested in Malaysia, and they did see, in comparison to sulfonylurea, hypos were better. Numerically, those who were on SGL2 DAPA had higher rates of thirst, but statistically there was no difference. We're completing 2 studies. One of them will be presented in Diabetes UK in March, and the other one 2 weeks later in Dubai in the conference of Ramadan. But of course, there are some patients you need to advise not to take an SGL2 in Ramadan. A person with renal impairment, a person with postural hypertension, a person on diuretics. So all of these are the natural sort of cautions for an SGL2 inhibitors. DP4 inhibitors, there were only 2 studied. That does not necessarily mean that the others are bad. I'm just quoting the evidence of what was studied. And when we did the first studies with vildagliptin, it showed a very good outcome even compared to gliclazide. So risk of hypos were less and glycemic control was equally efficacious. Sitagliptin did 2 large studies, but they only looked into hypoglycemia. Unfortunately, they did not look into glycemic control of HbA1c. So what we know of sitagliptin is it can be better of general SU, but equivalent to gliclazide. In general, a DP4 inhibitor would do what it's meant to do. The risk of postprandial hyperglycemia would be better, the risk of hypoglycemia would be low, and weight neutrality. GLP-1 receptor agonists, 2 have been studied, one much more than the other. Liraglutide had 2 or 3 studies. First was the British Treat for Ramadan study, and they went really for a very complex primary objective. They didn't really want to go for the simple one. As a patient, and I suppose as a doctor, you might accept a slight increase in glycemic control. So if my general HbA1c is 7.5 and I come to you after Ramadan is 7.7, you will say, okay, we can buy that. But what you might be worried about is admissions with hypos or frequent hypoglycemia. They went for a complex primary objective and they did not meet it between sulfonylurea, but the secondary objective in my mind are much more important. The rate of hypoglycemia, the quality of glycemic control, and obviously the weight reduction. The following study, which Novo did, is quite an impressive one on 343 patients from a number of countries across the globe, and the glycemic control was identical, but hypoglycemia during the month of Ramadan was lower than sulfonylurea, and as I mentioned, glycemic control was identical. So the study gave us confidence that a GLP-1 receptor would be a good choice during Ramadan. We did the first study of GLP receptor agonists. We did it on exenatide in UK with a group from London. It was a small study, what we looked into exenatide versus gliclazide, and the results were helpful. In my hospital in Dubai, after I moved there 3 years ago, they did a study on top of insulin, and they were basically looking into an observation of, are these patients better off or worse? And there was no increase in any of the negative outcomes that you can think of for a complex patient on GLP-1 plus insulin. So we know that a GLP-1 receptor agonist would, because of their pharmacodynamics, they would be helpful during Ramadan, the risk of hypos, the satiety and the postprandial peaks, as well as the effective reduction of HbA1c. But one other practical advice, obviously when you initiate any GLP-1 receptor agonist, there is nausea during the first few weeks. So I do not advise initiating pretty close to Ramadan. If you want to initiate a bit early. So by the time Ramadan is there, I got used to it and the side effects are lower. So if you want to initiate it early, but not a couple of days before Ramadan start, in case you have someone who's not well controlled. So this message is quite important. You really need to make sure that your patient is on a stable dose prior to Ramadan starting. Insulin therapy. Of course, the patient on insulin is a much higher risk because of the dynamics of his stage of diabetes, whether it's type 2 or type 1, as well as the type of treatment itself. So it is paramount that they will be checking frequently. Of the number of studies, and there are small number of studies, those of you who are interested in research, the field of Ramadan is a very virgin field. Whatever small study will do will have a significant clinical impact. So most of the studies looked on analogs, whether short-acting, mixed, or long-acting. They show that analogs are better when it comes to hypoglycemia. But as I said, large randomized controlled trials are little. However, hopefully in the End of Society in April, we have submitted the abstract. We're still waiting. We did a large study with Novo Nordisk on comparison of Novamix 30 versus Rhizodec, the combination of the Diglodec with insulin aspart in a 30%. Someone mentioned, Sarah I think mentioned, that many people do fast out of Ramadan. And if I'm on insulin, what we wrote in one of the papers, having a trial fast, having a mock exam the month before Ramadan might be very handy. Fasting for 3 consecutive days during the month before Ramadan, if the patient is desperate on fasting, maybe that would be one tool of understanding what she or he would do like. A mock exam is never like the true exam, but it might give you some insight. As I mentioned, many people, as Sarah mentioned, fast the 13th and the 14th and the 15th day of the lunar month. So if they do that for the month before Ramadan, it might give you some insight on how well they're doing. The adjustment of the doses is quite important. So for long-acting insulin, what we advise is to take it at iftar time, at the time of the evening meal. And the scientific rationale for this is, remember the CGM figures that I've shown you, that the highest rate of hypoglycemia is usually during the last few hours before iftar. So if my basal insulin is not through 24 hours, then I will run out of insulin during my vulnerable time. My vulnerable time, let's say in Australia, I'll be breaking my fast at 6 p.m. So my vulnerable time would be from 3 to 6. So if I take my insulin at 6 p.m., then I'll be running out between 3 to 6. That is when the hypoglycemia rate has been seen to be the highest. Should you reduce the dose or not? It depends on the pattern of the person, as well as the eating pattern of the person, as well as how tight the glycemic control. Now, maybe it's an opportunity to comment on your point of the patients on pump as well. Now, we deliberately are aggressive in cutting the dose at the first few days. We have already advised the person, you will be checking very frequently. The person's main point is, I want to avoid hypos. Now, if the cutting of the dose is too excessive, it's much easier to increase the dose rather than to have the bad experience of a hypoglycemia. But obviously, you would know your patients better, and you would be able to know from their own lifestyle on how much you'll be cutting on the dose. And much of this is not randomized controlled trials, but clinical practice on every day. But giving your patient an algorithm for dose adjustment is quite important. In Ramadan, we say, let's try to aim for a figure between 5 to 7 before you eat. And if you're lower than this, then cut down the dose between 2 to 4. If you're higher than this, then increase the dose between 2 to 4. So kind of part of empowering your patient is to give them a simple algorithm for their dose adjustments, so that they can understand. You're asking them to check, but what they're going to do with the results. They need to have some practical advice on how should I increase or decrease my insulin dose. And that applies to mixed insulins as well, whether it's once daily or twice daily or 3 times daily. 3 times daily, of course, you would miss the midday one, and the morning dose would be reduced by anything between 25 to 50%. And we know that 50% might be too much for some people, whether it's a pump or other types of insulin. That's why the range goes quite high. Here is a point of what someone asked about the mix level. We did this study in UK for iftar. It was Asian patients from Bangladesh, Pakistan, India, and the food is very rich in carbohydrate. They were already on mix 30 twice a day. So we advise them for the iftar, take mix 50 and keep it as it is for suhoor, because the amount of carbohydrate was less. Now for some people they do the opposite. Their morning meal is quite big in the morning rather than the opposite. So if you understand your patient, you will be able to tailor the treatment. What we saw in this study is that if the insulin matched the person's style, then it will work better, at least from reducing the risk of hypoglycemia. I don't think I need to cover the pregnancy again. It's been well covered, but it's just to stress, a pregnant woman without diabetes have a license not to fast. A pregnant woman with diabetes have 2 reasons not to fast. And I may just add one point. Structured education here is quite important. When I moved to Dubai, we provided all our GDM patients with an educational session of a group session. And we gave them a survey questionnaire to answer before the session and at the end of the session. Before the session, 95% said they will fast. At the end of the session, after 1 hour, 35% decided not to fast. Even better is those who fasted and developed hypoglycemic episodes, the vast majority of them, that was it. I've heard my nurse and my doctors what they said. I now had a hypoglycemic episode. That's the end of the fast for the rest of Ramadan. So education can change behavior. And I'm delighted that what Sarah mentioned about, do they listen to us? Yes, they can. But we just need to be courageous enough and not simply go with the flow. My patient wants to fast. I better just do a bit of tinkering with the medication and let them fast. I need to first give them the honest advice and then do whatever I need to do with the medication. And I think, of course, we have barriers with education. We have, for any education, I mean, this slide could be out of Ramadan. What are the barriers for education? And it does apply. It still applies for Ramadan. But don't forget the passion of the patient. The passion of the patient, they might not come for a general diabetes session, but they might come for a Ramadan diabetes session, because to them this is quite important. So that could be the carrot for the general diabetes management. And I will show you a very good example we did in Senegal. Before I just explain what we did. In both Senegal and Egypt, we have the same project but in different directions. We've decided to use the technology, and the 2 countries, we decided to send to our patients a message through the mobile, a very simple brief text message. Are you concerned about fasting in Ramadan, during Ramadan? If you are, then log on this website. And obviously, in some countries, there is so many diabetes societies, so to get away from the politics, we put it as linked to the European ESD, the desk which I belong to, so it's kind of a neutral, nobody would shout and say why this society or not that society. So it was easy. It's an international body. And one of the mobile companies gave us 500,000, 500,000 free text message in a campaign before the first week before Ramadan and the first week during Ramadan. Our usual login for our website, which is pretty basic, 20,000, 50,000 maximum in a year. During Ramadan, there were 200,000 out of 500,000 person receiving the message. And this is 500,000 of the general public. So maybe 10% or 15% of them have diabetes, but they were passing the message to each other. Now, Senegal is far much more sophisticated when it comes to diabetes than many other countries, because they have a diabetes register. So their messages was targeted to their patients. So the messages went from, and it was a project with the Ministry of Health took it up and the WHO took it up, and the messages were also including message of the day. So it's not just that you log in and you feel and you see a self-learning program, but there is the message of the day, whatever messages that we've picked up. So we basically picked up some of the information that we were giving on patient education to be self-learning messages. And as you can see here, in the beginning, in 2014, 3,000 persons registered. And then the following year it was 11,000. The following year it was 50,000. And these are people targeted for them. And this is what there was a response. We did a small survey for them. And just look into this small message. Do you want to receive SMS messages from M diabetes next Ramadan? 100% saying yes. Would you recommend M diabetes to your friends? 90% saying yes. So as we're talking about how can a difficult, busy professional, not every diabetic person have all the time to go to the diabetes center and attend a session of hour or two, but mobile technology as well as online technology is a very good tool to get to so many people in so many countries. So, in summary, as mentioned by Marwan, the prevalence of diabetes in Muslim countries is quite high. I reckon from your figures you said there's about just under 500,000 Muslim living in Australia, and with 22%, then we're talking about over 100 Muslim diabetic living in Australia. So there's quite a sizable number of people that would need your support and your advice. And the beauty is you're all keen, and you have so many people among you who are quite good in this, as well as skills and expertise. The recommendation of the IDF, we meant it to be practical. We didn't meant it to be rigid and not reflective of what happens in everyday practice. Education is the most important message. It's not necessarily what type of treatment I will give. That might help for some, but the most important is the education. The newer anti-diabetic agents, the DP4 inhibitors, the GLP-1 receptor agonists, and even the SGL2 inhibitors are showing some good outcomes compared to traditional therapy. Insulin analogs, all of the newer agents have been better than the traditional ones. For SGL2, at the time of writing the guidelines, they were very new and we only had one trial. Before this Ramadan, by a month or two, we'll have another 2 trials to reflect on as well. At the end of the day, a person on insulin is pretty high risk, and they need to understand that they are a very high risk. Hence, they will need to be checking frequently and doing the necessary dose adjustments. Pump are fantastic. They're a very flexible tool, and they could help a lot of people. But of course, they need the skills and the expertise from the diabetes team as well as the individual herself or himself. It's not right to say simple taboo. You must not and you can. It's looking into every single individual and trying to help them as much as possible. Raising the awareness and using all the possible tools, digital tools, online tools, leaflets, websites, meetings like this. Don't forget, educate your community, educate your media guys, your journalists, your community leaders, because their influence goes much beyond the 50 patients you might see with diabetes before Ramadan. And at the end of the day, the technology can play a huge role in this. What we've set in DAR, which is an alliance, by the way, it doesn't have an office, it doesn't have a secretary, it's just the passion of a group of people. And we have moved a lot over the last 5 years. The next international conference is in Dubai on the 24th and 25th of March. And because we have so many people with interest, we have also developed the DAR Research Network, which is a simple network agreement between those who are interested from any country, and it's open for more and more to join, and it's very flexible. There's no protection of data or no protection of ideas. You share the idea, and instead of doing it in one center or in one country, you do it in multiple centers and in multiple countries. The interest about Ramadan is really growing. I'm delighted to be here in Australia. It's most of the time I'm here for this event is my own annual leave, and in fact I go to work tomorrow morning. So we work on Sundays. So my work would never obviously give me all the time that I need. I have a study leave similar to everyone and an annual leave similar to everyone, and with not much flexibility. But I'm delighted to see that the French Society, the Francophone Diabetes Association, in their morning of their conference have set a symposium for this. And we have our group of people with interest from these countries, from France and Morocco and Tunisia, and hopefully they will have their meeting and the ball will start rolling. In UK, we have as I said, Jocelyn Harvard have asked me for the ground round on the 8th of May, which hopefully I will tag after the ACE conference. And the Canadian Diabetes Association have been in touch to say we're interested. The South Asian Health Foundation in UK have also set a meeting on the 16th of March with quite a robust program. And this year, the presentation by Ramadan will be quite different because in Dubai we've managed to get a grant and we have 5 clinical trials on high-risk patients. All of them are on CGM. It included type 1, type 2 on insulin, gestational diabetes, CKD stage 3, macrovascular disease. We want to understand more, and we want to be able to see what happens to the individuals so that we can tailor our advice in the future a bit better. Sanofi are conducting or in the process of completing a large epidemiological studies, mostly in the Middle East, and I think hopefully we can convince them to expand it for the following years to come out of the Middle East. The canagliflozin study will be presented in Diabetes UK. The other SGL2 trial on both DAPA and Cana from my hospital, there's 440 patients on all sorts of combinations with insulin, with GLP-1s, and we'll be reporting on this. And as I said, on the Endo Society, we hope our abstract will be accepted for the comparison between a randomized controlled trial on Novamix 30 versus Ryzodec. And colleagues from UAE as well as Saudi Arabia did studies on type 1 comparison of pumps versus MDI, and that will also be presented. Ongoing studies for this year, there is lixexenatide with glargine, study in 7 to 10 countries. There is a cohort for optimum care, and what we call with optimum care, we'll start with MDI, not pumps, CGM, expert advice, as well as standardized dose adjustment and algorithms. I know there's 2 dapagliflozin studies, one in UK and one in UAE. Next year, as I said, there's plans of sulfonylurea gliclazide MR versus other treatment. Boehringer are interested in doing an empagliflozin study, and there is plans of a type 1 study across many countries with CGM. And that's what I know of. I'm sure there's a lot more that other people are doing and I'm not aware of. It's a long journey. We are in the beginning of the journey, but I think we have done a lot over the last 12 years. I'm delighted with where we are. It's still very, very early stages of evidence-based medicine, but with enthusiasm such as yours coming on a Saturday, it's quite encouraging. Thank you all.
Before we take questions, I just want to give them a couple of things. Unfortunately, one of the little presents I want to give you is in Storage King somewhere. It got moved from my house elsewhere. But this is a little boomerang to make sure you come back. And it's,
Thank you very much.
And I made sure it's made in Australia. It's not made in China or Vietnam.
Thank you very much.
And there's a little bit more of the caloric content while you're on the Emirates flight. Yes.
Thank you very much. This is very...
Thank you very much. It's absolutely been fantastic. So again, thanks for tying it all together, giving up, I think, some very, very precious time. The flight's at 9:30 tonight, so he lands, I think, 5 a.m. Sunday and goes to work. Jahangir, that's pretty impressive, isn't it? Yeah, good. Okay, so we've got about 15 minutes or 20 minutes for questions, and please, make use of Mohamed. There's no one else who's going to be as knowledgeable, I think, in this area. Questions? Please, yes.
Hi, I'm Veronica from Blackdown.
I think my question has been answered from what you said. I was going to ask before a dumb question. With fasting from before sunset to sunrise, is the person can't even have a glass of water or a sip of water?
I was meant to say this and I forgot, and thank you for asking the question. The fasting as a religious act is a complete fasting for anything oral. By anything, it means anything. Food, drink, tablet. The point is, if you need to take a tablet, then you're exempt. The problem is many people are keen to engage in the activity, the passion, the atmosphere, and they try to maybe postpone the treatment. So what the religious authority says, if you as a healthcare professional see there is no difference in altering the timing of the medication, let's say I need to take an antibiotic, and you can find me an antibiotic that I take once daily as effective, fine. But if my antibiotic, my sensitivity is every 6 hours, then I'm exempt.
I see. And the other question to do that, you said, you know, people need to break the fast because of hypoglycemia or whatever. Do they just pick it up the next day and fast the next 24-hour period?
Very good question, and thank you for asking it. Ramadan is 30 days, is a month, whether it's 29 or 30 days. If I break my fast on any day, and it's a temporary issue, not a permanent issue. Let's say now it's a permanent issue, I have hypo unawareness or on dialysis, and my doctor said to me, stop, don't fast. I don't have to repay. All I need to do, if I have the money, I would donate the equivalent of food of my daily food. So you see what you eat every day and you say, okay, that's my average meal, and then you donate that food or equivalent money on a daily basis. But if your problem is temporary, let's say a young lady menstrual cycle during Ramadan, then she is free to choose any days over the year to repay for these days that she did not fast. One other point, which is obviously a bit more of the in-depth religious issues, which Sarah has alluded to, and I've heard it from a high level of the scholars. Pregnancy is often followed, of course, by breastfeeding. So if this month the lady, or this year the lady has been pregnant and she's got 30 days to compensate, and then the following year she's breastfeeding and got another 30 days to compensate, it becomes 60 days. It's quite a burden. What they're saying is, if 2 consecutive years come to you with reasons not to fast, you're exempt from repaying back. And the other thing which was apparent, because of this is importance of community input, some poor patients are not aware they are not obliged to repay the money when they're not fasting. So they were fasting because they were poor, so they don't have the money to repay. And they didn't know, if you ask the proper religious authorities, they will say to you, you only repay money for your non-fasting when you're able to do so. So that's why I'm saying it's very important to have on board your religious leaders to propagate the right messages.
There was a question down the back, and then Marlon, and then Sylvia. Up there, was there someone? Oh, right, the mic hasn't got up yet.
I was interested about the slide in terms of hunger throughout Ramadan, that men have more hunger than women, and I guess the role of GLP-1 in terms of hunger, and whether there were any studies, now that we've had GLP-1 inhibitors for some time, that were allowing, that it was easier for people to fast with the hunger during the day, that it was less of a burden fasting on a GLP-1. And my second question is around SGLT2s and DKA. There is some concern around SGLT2s and very low calorie diets. Now, that's a different 24-hour, day after day, but are you aware of any clinical cases of ketosis being generated during the day
Sure.
and increasing the risk of DKA on an SGLT2?
Well, thank you very much for these two important questions. For the GLP-1, it's not really been studied as levels between men and women and whether that is contributing factor. One of our co-researchers is quite interested in the physiology of what happens during Ramadan, and he's currently conducting a number of studies, and I'm looking forward to hear what he will tell us in March in the conference. As for the SGLT2s and ketosis or ketoacidosis, of the experience, because obviously we have them now for the last 2 or 3 years, and I have not seen a single case from my colleagues, and of the data of the studies that have been conducted and not been published yet, which will be published very soon, I can confirm there was no DKAs.
Thanks, Mohamed, for an excellent presentation. Just a question regarding the use of insulin during the fasting period. And my understanding is that it's okay. However, a few years ago I looked into it, and my understanding that it was decreed that it was fine in Australia. But in the actual IDF guidelines, there is a chapter written by another author where he talks about injectable medication during the fasting period. What is the position on that with respect to patients? Does that constitute breaking the fast? So that's a type 1 patient, for example, needs to take a small dose of rapid-acting insulin at midday to bring his glucose level down, who's not going to eat at the same time. What is the position? Because there's a little bit of conflict. I've had the question asked to me by a number of people when I've given the presentation. Just what your comments on that?
Sure. And I think you're right to ask the question. It's quite important that we understand that obviously Muslims come from a very large number of countries. There is Sunni, there is Shia, and there is different ethnicity issues. And I understand that some have an issue with injections during the fasting hours. Having said that, there is 2 points to make. One is the general regulation of necessities allow what is forbidden. So because if I have type 1 diabetes and I need to take an injection, that's considered as a necessity. So it will automatically be okay. In general terms, there is no problem to inject during fasting hours. Because actually it applies also to the point of, do I want, now it's not, let's say, it's iftar time. Should I wait until I eat and then have my insulin injections? Because normally we'd say, you'd have your injection, then eat. And there's no need to do so. So insulin injections do not violate the fast, at least for the vast majority of Muslims across the globe.
Okay, Sylvia and then Stephen.
I had 2 questions. The first was whether there was any evidence of an increase in DVTs or renal dysfunction in SGLT2 patients who are fasting during Ramadan, particularly in hot countries, either positively or negatively. And my second question was, we've talked a lot about the personal decision-making on behalf that patients have. Could you elaborate on how you would discuss it? Say someone's a taxi driver or bus driver at moderate risk of hypoglycemia or high risk of hypoglycemia. How does that affect the nature of your discussion with them, where the risk is to others, not just themselves?
Sure. I think you're all quite experienced and you will use your usual tactics when you are discussing with your patient on the individual risk. Knowing that your bus driver or your taxi driver, let's say that now your patient is not willing to go on insulin because of losing their job. Forget about Ramadan now. You go through lots of tactics, discussions with the individual. The same when it comes to Ramadan. I think the easiest thing is to still use the religion. I had one of my colleagues a while ago asking me on a plane, how can I convince some of my Asian ladies, he was a geriatrician, to do bone mass density for osteoporosis? And I said to him, talk religion. He said, what do you mean? I said, in Islam, my body is a gift. I need to protect that gift. So doing the bone density scan would protect me against having unnecessary fractures. So equally, if you were to say to your patient, you're fasting for your God, so would it be appropriate to put people at risk because of your religious act? And that probably will make them think twice. But the beauty is you have options of treatment options. Should I switch his hypoglycemic drug to a less hypoglycemic drug? that would be quite important. Your other question was about SGLT2 and DVTs and renal impairment. We've noted no increase in this. In fact, we haven't seen in the literature any increase in DVT, and the thrombosis that was seen in Saudi Arabia in retinal vein was only one study. Don't forget that Ramadan is intermittent abstaining from fluid and food, and then it's feasting afterwards. So it's not prolonged fasting as we know of 72, 3 days, 4 days, or whatever. It's 12, 15, 18 hours, and then you replenish your body status and beyond. Stephen?
Stephen?
Yeah, thanks very much for a great talk. I have a simple question. Are there any data on how many people with diabetes will not break their fast despite having a hypoglycemic episode?
Yes, we have published some work from 4 countries out of our education. In our standard survey, we asked people about whether they had hypos or not, and what did they do when they had hypos. And it is sad to see that 25 to 30% do not break their fast when they have hypo symptoms. But there is one possible reason for that as well is the vast majority of them were not testing. And the symptoms of hypoglycemia overlap a lot with the symptoms of simply fasting Ramadan. So many of them as kind of, is it hypo, is it not hypo? They ignore it because the symptoms are mild. And it's quite interesting that our guidelines are saying you should break your fast with blood glucose of less than 4. We are seeing with CGM a lot of people between 3.5 to 4, and they're not breaking their fast. So one, they feel confident because of the CGM that, well, it's stable. But the reality is they did not listen to our advice, and they carried on fasting.
Thanks.
But it's about 25 to 30% are not breaking their fast.
From the practice point of view, type 1 diabetic who we fail to persuade them away from fasting, how do you go with these kind of group of patients? Do you prefer to keep going with the pump there on the pump? Do you cut down? Do you go basal bolus? If the sugars goes high during the day, do you advise them to correct or not correct? And how would you go with the insulin sensitivity factor, the carb ratio? Do you adjust it up or down? I have absolutely no idea.
Yeah, that's a quite an important area, but the beauty of Ramadan is it doesn't come as a surprise. We all know when is Ramadan of this year and when is Ramadan for the next 500 years, if you wish. So it's all about forward planning. It's all about discussing with your type 1 diabetic this decision well in advance, and ideally based on the previous Ramadan as well. Pump is a fantastic tool for the right person with the right center. So if your patient is well suited for a pump, then that would be a very good tool. Of course, the basal dose would need to be adjusted. How much is it is based on the individual and practice. I would say in general, be a bit generous in the beginning. I should be monitoring on a regular basis, whether CGM or SMBG. So ideally, I should be able to correct quickly. And make sure to have a hotline with your patient, a telephone number that they be contacting for some advice. MDI is also quite possible for them to fast using MDI with carb counting. Carb counting will really be quite important. The role of the educator and the role of the dietitians in Ramadan is really paramount. Much more important than me.
Shauja?
You mentioned a Ramadan plate.
Yes.
We'll just get
What would be in a Ramadan plate?
Okay, so I've shown you that we are already in the final stages of developing the RNP, the Ramadan Nutrition Plan. With the nutrition plan, you basically will put your weight, your height, will come your BMI, and then we'll ask you a question about whether you want to keep your current weight or lose weight or increase weight. So we'll give you a total calorie. And then it will give you the 7 days menus. But we know that the menus could be restrictive for some. So what I'm trying to currently develop, and I'm hoping to be able to finish it before Ramadan starts, is to do the process of create your own plate. So my plan, I hope that the web designers will help you to develop this, is basically here is my plate, and I decide on what drink I have. When you put it, it will give you the calories and carbohydrate. What starter, what soup, what salad, what main course, and so on, what dessert. And as you put, you would see the carbohydrate content as well as the total calories. So then you can make your own informed decisions of, yeah, today I will go for the Lebanese dessert and the dates and the sugary drinks, but this is my weekend, and tomorrow I'm going to behave, or no, my food is fine. And I think that will, the beauty of this is not Ramadan, this is any day of the year. But the likelihood of the person logging in on this in Ramadan is much higher than normal days.
Okay, I
One
think
more
one more
Sorry,
question.
we have one long-acting GLP-1 agonist in this country that's PBS reimbursed, that's exenatide MR. Are there any studies that you mentioned earlier that have been planned?
For GLP-1?
Bijurian.
Yes.
It's the one that we have available.
Yeah, we were discussing that
PBS reimbursed.
we were on the verge of having a Bijurian study about 5 years ago. I remember sitting in the ESD of Lisbon and and as an advisory board for which European countries will be taking part. But then Lilly left Bijurian, and I don't really know whether it will be taken up by AstraZeneca or not. But we're pushing for this. I think sometimes we need, I mean, it's great that the pharma industry have moved to understand a bit more about the importance of Ramadan. I remember talking to the CEO of Sanofi in one conference, and I said to him, what are you going to do about 23% of the global population? And he looked at me, what do you mean? And I said, Muslims. And he said, oh, our products are halal. So I said, well, it's not about halal, it's about Ramadan. And he said, I have no idea, but give me time and I will get back to you. And the following year, the vice president of Sanofi came to us. They want to support Ramadan. And indeed, I'm thankful for the support for producing the guidelines. They had no influence on the material, but they helped us in the printing and the design of the, it wasn't my clever design, these slides. It's professionals, designers who made this. So I think what we're moving towards now is two things. One, there is the interest of all of us, and potentially we can do the studies without necessarily the input of pharma industry. But also the pharma industry have really realized that this is quite an important area. And if the drug could be suitable for Ramadan, then it would be suitable for... Ramadan is just an example of extreme lifestyle change. So what applies for a Muslim in Ramadan would apply to anyone in a different culture, or a different type of lifestyle, not necessarily fasting, just missing food for whatever reason. If I can miss my food for 15 hours or 12 hours in Australia, I'm interested in Chile with 9 hours, I'll go there. If I can miss my food for that number of hours without hypo and sustain good glycemic control, then potentially if I'm just missing my meal because of in a business meeting or traveling, then maybe it will be okay. So what I'm trying to say is, maybe it's an opportunity for us as people with interest to do these studies. And I'm sure the pharma will be keen on doing some as well. So in short, no study on a GLP-1, a long-acting one, for this year.
Well, perhaps we can find out whether there will be any in the future for Volvers, our pharma colleagues. Well, before we finish and have lunch, I'd like again for you to join me in thanking Mohamed. Thank you very much indeed.